Just earlier, you mentioned diabetes as a condition that can lead to CKD. I know that diabetes is primarily diagnosed as an excess of glucose in the blood. What beyond that in testing would lead to a diagnosis of chronic kidney disease?
Well, you have to do a test. Usually they're called the creatinine. So it's a blood test. And creatinine itself is not a toxic substance, but it's excreted sort of fairly substantially by the kidneys. So when the kidneys aren't working to get rid of the creatinine in the blood goes up. So you measure it and you see this elevated blood creatinine. And that's when you know you have kidney disease. The other thing is to do a urine test, because if you start seeing large amounts of protein in the urine, then you also know that you're developing kidney disease. So a blood test and a urine test. And the idea is, again, sometimes people get protein in the urine and think, oh, well, maybe I'm eating too much protein. That's not it at all. The kidneys, what they do is they act sort of like a sieve. So if you think about when you're washing blueberries in the sink, for example, you put it in a sieve or a colander, and then the water goes through into the sink. The blueberries stay in the colander so that you can eat them. The same thing with the kidneys. So the kidneys, they basically let all the urine through, but they keep all the protein inside because you don't really want to lose that protein. That's precious stuff. So you should really have very, very little protein in the urine in a normal situation. If you start seeing blueberries in the sink, there's nothing wrong with the blueberries and there's nothing wrong with the sink. The problem is that you have a big hole in your sieve, right? That's letting those blueberries fall through. And it's the same thing with the kidney. So when you start seeing protein in the urine, it doesn't mean that you're eating too much or too little or the wrong protein. What it means is that your kidney has a big hole in it that's allowing that protein to fall through. And that's often the earliest sign that you'll have kidney disease, even before the blood tests become abnormal. Because by the time the blood tests get abnormal, you've already sustained a significant amount of damage to the function of that kidney, because the kidney is not cleaning properly. So you're already at 50, 60% damage to the kidneys by the time you see it in the blood. So that's why it's important to do the blood test and the urine test. And they're fairly routine. So when you do a typical sort of, yearly checkup, the kidney function is often included in that. Urine tests will often pick it up as well. So that's the sort of yearly sort of wellness check that a lot of people do. It's important to do that because it's on those routine screens and you'll be able to pick it up early. For blood pressure, of course, it's about monitoring your blood pressure. So these days it's a lot easier. 20, 30 years ago, you had to go to your doctor to get your blood pressure checked. Now, of course, there's a ton of home monitors, which is a pretty good idea, but there's also monitors at a lot of pharmacies all over. You just go there, you sit down, you check your blood pressure. It's free. There's no needles. It's non-invasive. So it's really important to check your blood pressure routinely. Like, not that it's a problem, but it fluctuates all the time. So therefore, if one reading is high or normal, it doesn't mean the next reading won't be, normal or high, right? So it's important to check it. So blood work, urine tests, and blood pressure are probably the most important things, and they're easy to do.
The situation you described of having these holes in the kidney, is this a consequence often of the elevated glucose in the blood? Is it basically toxicity of too much sugar that's damaging the kidney?
Yeah, in the case of type 2 diabetes, or in the case of diabetes, yes. But there's lots of different things that can cause it. The most important would be high blood pressure and diabetes. Diabetes typically causes a lot of protein in the urine. High blood pressure does not. There's other diseases as well, glomerulonephritis. These are rarer diseases, polycystic kidney disease. So any of the kidney diseases can cause it, this protein in the urine. So it doesn't mean you have diabetic kidney disease. It means you have kidney disease, of which the most common would be high blood pressure and diabetes.
What kind of physical symptoms might people experience? You mentioned some, like a kind of fatigue being a factor in this. What kind of signs might they see in their body that they're heading towards having a kidney disease?
Yeah, so by the time you actually feel it, your kidneys are mostly gone. So that's why you can't really leave it to the symptoms. It's not like a cold where you'll get a fever or a cough and then you'll be able to pick it up sort of quickly. Kidney disease can go on for decades, really, without anybody knowing about it. And it's picked up just on a routine test. We see people, for example, they get a test for insurance or a test for, work or something like that. And then boom, it's like, whoa, there's a lot of problems here. But they didn't feel it themselves in any way. No change in the urine, no difference in the urine, no anything. And that's typically the case. By the time you get the symptoms, the kidneys are sort of 90-95% gone. And oftentimes by that time, because it's so advanced, it's often irreversible. But the signs and symptoms of the fatigue, the nausea, the vomiting, this sort of sallow complexion, that's when things are really, really, really far gone.
And in terms of medical treatment for CKD, I imagine you'd be focused largely on treating the high blood pressure or the diabetes, being that those are primary causes of CKD.
Yeah, so this is why it's important, because you have to identify what's causing the kidney disease and then take care of what's causing the kidney disease. So in the case of high blood pressure, you want to treat them with high blood pressure pills usually, or diet. And by taking away what's causing the kidney disease, you hope to slow it down. As I said, kidney function declines over time anyway with age. So you almost never stop the decline of kidney disease, but you want to slow it down to what it was before, not this sort of quick decline, but just a slow decline. The other thing is for diabetes is just the other major issue. I mean, there are other ones. There's myeloma and there's polycystic kidney disease. There's all kinds of inflammation in the kidney called glomerulonephritis. So those have specific treatments, but they're relatively uncommon and rare. Diabetes is the same thing. Diabetes can cause kidney disease. In fact, it's the most common cause of kidney disease and kidney failure, which leads to dialysis. So just to clarify what dialysis is when your kidneys have basically completely shut down. What we do, because the kidneys normally clean the blood, is we take the blood, we clean it with the artificial machine, the dialysis machine, and then we give it back to the patient. And because the blood will get dirty again, then you have to do this usually 3 times a week so that you keep cleaning the blood. Because as soon as you come off the dialysis, the blood starts to get dirty again, and then that's what happens. So yeah, if you identify the diabetes, then for type 2 diabetes, you have to understand that type 2 diabetes is a reversible condition. So if you can then intervene when they're, before they have a lot of kidney disease, and you reverse the diabetes, then you're going to reverse a lot of the damage, a lot of the sort of accelerated damage that happens with the diabetes to the kidneys, and hopefully, prevent somebody needing dialysis.
In terms of dealing with the high blood pressure cause of CKD, what kind of medical treatment is standard in that case?
So there's the non-pharmacologic and the pharmacologic. So the non-pharmacologic in terms of as in not drugs. Certainly doing more exercise, weight loss, those are probably the most important things. People used to talk about salt restriction in the past, but it's really not that effective. The salt restriction in terms of reducing blood pressure. For some people it is, but it's actually the minority of people that have a huge reduction in blood pressure when they eat less salt. Weight loss is quite effective, and changing the diet to low carbohydrate diets can be very effective. Some people notice that their blood pressures actually drop very significantly on that. So those are a couple of the things that you can do from a non-pharmacologic standpoint. Then from a drug standpoint, there's multiple classes of medications that have been used for decades. At least 6 or 7 different types of classes of medication that can be used for high blood pressure. And they're really quite effective. So for the most part, people can get control of their blood pressures through a combination of non-pharmacologic and pharmacologic measures. The targets have actually changed also for blood pressure in the past. So 20 years ago, the sort of consensus was that blood pressure should be 100 plus age. So this is something that was 25 years ago. So if you're 70, people would say, well, your blood pressure of 170 is okay. It's not okay at all. That's old sort of medicine. So the targets for blood pressure were 140 on the top. So blood pressure there's a top number and a bottom number, right? So it's like normal is 120 over 80. Both numbers are important. So the target for the top number is 140, and the bottom number is 90. So anything, if the top is over 140, then it should be, you need something to bring it down. If the bottom is over 90, then you need something to bring it down. So it's either or. What's the difference between the two? Mostly it's age. So people who are younger, who are less than 55, should really be looking mostly at the bottom number. That's the one that typically is high if they have high blood pressure. People over 55, it typically is the higher number that causes a problem. So that's the difference. The blood pressure for people with kidney disease is even stricter. It's actually 130. So you have to, instead of being under 140, they want it under 130. And again, the other thing is that the blood pressure fluctuates. So if you're under a lot of stress, your blood pressure might go up, for example. So we're only interested in treating it, particularly with drugs, if the blood pressure is sustained high. So if your blood pressure goes up to 150, for example, that's high. But then because it was due to whatever stress you had, and then the next day it's 120, you don't need to treat that. So usually when you initially are looking at the high blood pressure, you should treat it, you should measure it over several periods of time, and usually over 3 to 6 months before you actually start treatment with drugs, because it just might be a temporary thing, right? It's exam period, your pressure's high, but then after exams, then everything goes back to normal. Well, you don't need to treat that. It's only if it's high all the time. That's where it's dangerous.
And is there a particular medication that's favored by nephrologists, kidney health specialists like yourself in treating the high blood pressure?
There's a couple of classes of medication. So in the past, again, there's been drugs for 50 years, and the old ones that used to be used a lot were the diuretics, which are water pills, and the beta blockers. Because of side effects, that is, they can cause other side effects, most people in the last 20, 30 years have switched over to two classes in particular. One is the ACE inhibitors, which is things like ramipril or perindopril, lisinopril, or this other class called the calcium channel blockers, and those are drugs like amlodipine or Norvasc, for example. So they tend to they're once a day medications compared to some of the older ones, which are twice a day sometimes. And also they tend to have less side effects than the older drugs. So most people use, those drugs right now.